Thanks, Jonathan. I'd also like to thank the organisers for asking a pharmacist to come along. I've been coming to this meeting for quite a few years, not the whole 10 that it's been going, that Tony told us about this morning. And I've always been the only pharmacist. But this year there's 3 of us. I'm so excited. All of my spruiking for it has obviously got out. So hopefully next year there'll be some more. So looking at the pharmacist perspective. Okay, I'll keep talking. I guess, oh look, there we go, magic. Looking at the pharmacist's perspective of what the safety issues in ICU might be, I would suggest that they are my perspective, but they're also important to everyone else in this room as well. I've chosen not to look at specific diseases, syndromes, or even processes necessarily, but sort of medication safety as a whole picture and why that's a priority in ICU. It's a priority everywhere. It's actually the World Health Organisation's priority at the moment, and just recently, in March this year, they updated their 10 facts on patient safety at the World Health Organization. Medication harm and waste was number 3 on that list. It costs something like $40 billion annually, medication errors across the whole health system across the world. And in Western countries, that cost is probably amplified. So the number one thing I want to talk about is the patient. Our patients are sicker than the rest of the hospital, than the ambulant community population. And as a result, for a very long time, so the paper on your right, was from 2008, but there are many papers before that as well. We've accepted the fact that medication errors happen more often in intensive care. They usually have worse outcomes. There are quite a few patient factors associated with these sorts of outcomes. Patients are sicker. They're on twice as many drugs as they're on the ward, and they're more likely to be on more IV medications than not, and IV medications have a bigger risk associated with them. Our environment is fast-paced, things change quickly, and we're also interrupted all of the time by alarms, other people, things going wrong. But one of the most significant things from my perspective is that we remove the most important safety measure from the system quite a lot of the time, the patient. They can't tell us they don't take that drug anymore or they're allergic to that particular medication. So it's not something we can easily fix, but it's something that we need to consider in the systems that we build to try and protect our patients. The number 2 on my list is staff. And I'm not saying there's anything wrong with our staff, but it's how we can interact together as a team to reduce the risk for our patients. Many of our medical staff, particularly our junior staff, are rotational and transitional and come into a new unit expected to do their job in the first hour of the first day without any real orientation to the way that unit works. And we don't all work the same way as much as we'd like to say that we do. Maybe the Kiwis all work a little bit more together than the rest of Australia does, but maybe not. And our nursing staff numbers are huge, as Michelle alluded to this morning. Education for a huge group of people to the same level all of the time can be a really big challenge. And we also have a higher turnover than some other specialties, and as Michelle was also talking about, an increasingly junior level of nursing staff. And to me, there's a risk there with the loss of corporate knowledge. So the consequences of these staffing factors for our patients and medication safety, really with medical staff, there's unfamiliarity, can lead to confusion, and sometimes that can lead to conflict, which is never in the patient's best interest. Trying to get a message across is difficult, and to make sure that it's understood is even harder. For example, in the very simple context, when dexmedetomidine was first introduced in the unit I was working in many years ago, we wrote a guideline. We had education sessions. We talked about it at handover every morning for about 6 weeks. However, one of the first times that I saw it used in a patient that we really, really wanted it to work, the nurses at the bedside, actually, there was more than one in this particular patient, was still struggling with how to use it and resorted to what they knew. They knew that other sedation, if you bolused it, you'd get a good effect and the patient would settle down. It's not going to work quite the same way with dexmedetomidine, and the patient got very, very bradycardic and hypertensive very quickly. And another example that is probably more complex, is I'm starting to show my age in intensive care a little bit, is when sedation breaks and sedation holidays were first introduced. Everyone read about them and thought they were a great idea, but as a team we didn't really sit down and talk about how were we going to do this in our unit, how was it going to be managed at the bedside, what were the safety measures we were putting in to make sure our patients were safe, and conversely that our nursing staff at the bedside were safe as well. And this loss of clinical risk corporate knowledge, I don't know how other to describe it, and it's not described in the literature from what I can see. But we've designed a lot of risk out of the system around medications. And one of the simplest things I can think about is we took away potassium ampules pretty much from everywhere in the hospital. Because if you gave them to patients, you either severely damaged them or you killed them, pretty much. We still have them in the intensive care unit in some units for different uses, and they're starting to move out now that we've got Foxilium and all these other funky products. But not too long ago, I was involved in an incident where 10 doses of peripheral IV potassium were given overnight to a patient through a peripheral line. You can imagine what her arm looked like the next day. It was blistered from one end to the other. The junior staff on overnight hadn't stopped to think about why we don't usually do this for a patient with a peripheral line. No one had asked for help until it became obvious that there was a problem. So there's something we need to do around making sure that people understand why we've engineered things out of the system and that that knowledge is passed down. Number 3 comes in 2 flavours. Variation in practice. And it's really hard to pick up on variation in practice in administration. It's actually really not well documented in the literature. But sorry docs, prescribing variation is very well documented. This is a really nice quote from quite a few years ago now, but I think it still holds true for a lot of new fandangled treatments in the intensive care unit. And I think a really good example of it would be our story with delirium, and now I'm really showing my age. 20 years ago when I started in intensive care, we gave antidepressants to everyone. If you weren't on vitamin C, citalopram, by the time you left, you hadn't had a good enough stay in intensive care. Perhaps we were treating hypoactive delirium in our patients. Then we moved on to using IV haloperidol in doses that now make me shudder. Then we thought, well, we'll get those hyperactive delirium patients with some sleep dose propofol. And then we moved on more recently, and especially we started this in Melbourne, I have to apologise for, IV olanzapine, again in extraordinary high doses. So I think that's just a nice example of how fads come and go and are not always evidence-based. Activating protein C probably falls into that category a little bit as well. And the high-dose vitamin C for sepsis and pretty much anything else that you can't think of anything else to treat it with. But probably more disturbing is the systemic variation in practice. This is 3 pieces of work over the last 10 years, pretty much. The one on the left is UK data from 2007. A group of pharmacists and intensivists just asked people in a voluntary survey, how do you make up your inotropes, vasopressors, sedation, a few other bits and pieces, and you can see there's a really broad variation. My favourite is the phosphate replacement, which you can imagine because it can be a bit, you can do more with a phosphate ampule, 45 different ways to administer phosphate to a patient. I was part of a group who replicated this work with pharmacists in Australia, and our data is on the right. It was almost 7 or 8 years later, and it really didn't change much. Some places had actually adopted the UK suggestion, so there was a little bit of a reduction in practice. There's still a huge difference in what's going on. More recently, the pharmacist team, led by Robin Ingram and Melissa Ancrabs, who have developed the standardised inotrope guidelines for Victoria, for Safer Care Victoria, measured Victorian practice. For 6 inotropes, there were 16 different concentrations that were used, and for 3 vasopressors, there were 11 different concentrations used across Victorian adult practice. So there's still a lot of work to be done in that space. Number 4, and Gladness talked a bit about this, and I won't harp on about it because I don't think there's an answer. We all think that e-systems are going to fix all of our problems, and they are going to fix some of them. They're going to create new ones, and the jury's really out about whether they're going to make our prescribing practice anyway any better. Again, there's very little data about administration in this space. The only one that does is the one in the intensive care unit on the right that said initially it didn't really make any difference at all. But once that system was matured, and the authors don't talk about it, but I'd suggest they managed to get some data out of the system, as John was saying, and improve it and embed it better, they did see a reduction after 2 years in their medication errors overall. And my last worry is probably the most important because there is no solution currently. The drug shortages that we've faced over the last 5 to 10 years have just become a bit of a joke, I think, in most intensive care units around the world. The Americans have really looked at this in a bit of detail. So over this 5-year period that they looked at, there were almost 2,000 drugs that were in short stock or short supply across the US. Half of those were needed for use in intensive care units and in critical care. They think that they've reached their peak and it's getting better, and that's by quite a bit of lobbying of the pharmaceutical towards the pharmaceutical industry, but it's still a problem, and we feel it here all the time, especially around antibiotics. I think most people would be able to recall that to mind. People have tried to measure the impact that this has. In paediatrics, this study looked very specifically at fentanyl and benzodiazepine, which were in short supply in a paediatric unit, and they looked only at prescribing errors, and they didn't find really any problems. However, the shortage of noradrenaline in the US was associated with an increase in mortality of about 5%. So to me, that sort of just says, well, the number of errors that happen are maybe not what the problem is, but we should be looking more about what the severity of the errors that are associated with having to swap in something that you're not used to using in, and again, all of those problems about trying to get that message out quickly and reliably to your whole staff become a big problem. But it's okay, it's not all doom and gloom. There are some solutions and some mitigating things that we can put in place. I think going to standardised practice around a lot of medication issues is one of the ways forward. New Zealand seem to do this much better than us here in Australia. We're really struggling at Safer Care even to do it at a statewide level. Because once you standardise practice, then you can start to standardise the systems around that practice. And I think our guardrails or I can't remember what the other brand is called, sorry to use brand names, but the safety systems built into our infusion pumps are a really good example of that. But they only work if everyone is doing the same thing. Within Safer Care, we're trying to standardise practice around 9 inotrope medications and vasopressors, and we're trying to present a single concentration for everyone to use, whether you use syringe drivers, whether you use volumetric pumps in your unit, that everyone is able to use that, and so at least setting a standard, because we move patients around more than you would think. We also need an effective medication management team, and I'm not just talking about pharmacists and pharmacy technicians. I'm talking about everyone, because we all have a role in patient safety. Doctors, nurses, pharmacists, technicians, and now, as Gladness said, or I can't remember, maybe it was Michelle, there's another member of our team, and that's our electronic information systems and the supports that need to go into those as well. So our team's getting bigger, but we need to focus on every step in that pathway to make sure that we don't harm our patients with the treatment that we're trying to give them. Thank you.